till now where we have actually, what would be the newest opioid?
I don't know.
OxyContin's pretty new, though.
OxyContin is not the newest, but it's newer.
All right. What's the purpose of an opioid?
Pain relief.
A doctor's purpose for prescribing?
Pain relief.
Pain relief. And that is the number one reason, or is that the only reason a doctor should prescribe an opioid?
I believe so.
All right. Demerol, if it has been around for as long since you've been a doctor, do you see a lot of Demerol addiction in
No.
your practice? Do you know? Can you tell us why that is?
I think OxyContin is more readily available. It's probably more potent as well.
When's the last time you saw a Demerol addiction?
I don't recall. A long time.
And that was when they were giving it in pills. Is that right?
I think it's always been available, both injectable and by pill.
Okay. Was that what you saw was pill addiction? Or do you remember? Do you remember?
Tell me your question, please.
You said it's been a long time ago.
I don't ever recall recently seeing Demerol addiction.
When you are treating an opioid addiction, whether it be OxyContin, Demerol, Dilaudid, do you see the same types of symptoms in those drugs in your patients?
Symptoms
when they're, in other words, the same effects it would have on your patients when they're on the drugs, the same withdrawal symptoms that they have when they're off the drugs. Do you see this?
Similar.
Similar. And what would be, let's say an individual came to you with a problem with painkillers, OxyContin, let's say, or Demerol. What would be the course of treatment that you would suggest once you determined that they were dependent or addicted?
Stop the medication and seek treatment to ease the discomfort associated with stopping the medication. And that's the primary reason that those people present to my office.
Let's talk about, do you find it difficult to convince addicts to stop medications?
Well, people come to me because 99.9% of the time they recognize they have the problem and they're presenting voluntarily to get proper treatment.
And despite all that, despite their best intentions and desires, do you still find it difficult to convince them to stop using the drug?
No. The ones who present voluntarily want to stop the drug.
Okay. And what treatment program do you provide for them to help them get off? You say stop the drug. Do you just stop it, say just stop it, and then go home?
Well, the first thing I always suggest is that an individual go to a treatment facility where they can get well monitored and well treated and properly assessed for their addictive disease and, again, the comorbidities, so that they can get treatment from an addictionologist, from a psychiatrist, from a therapist, and get proper vital signs monitoring and get state-of-the-art treatment.
All right, and so you would recommend them to a particular facility?
Any facility.
All right. After you recommend them to that facility, do you continue to treat them in that facility?
If I consult at that facility, I'll treat them there. If they go to another facility, then they'll be treated by the physicians that work at that given facility.
And let's talk about stopping painkillers. If a particular individual you've made a determination they're addicted to painkillers, do you consider it safe for them just to go cold turkey, so to speak?
It's not safe, but it's also extremely uncomfortable. And most persons who have addiction and are not in denial about it have tried themselves to discontinue and have met failure. And that's why they present. They're very fearful of the discomfort associated with cessation of their opioid use, and so they're coming for appropriate medical help.
All right, let's talk about those individuals that that do have a problem with denial. Explain what that is, a denial problem in your practice.
Well, people who are in denial about their addiction basically are just dishonest. They tell all the people around them, family, friends, etc., spouses, children, parents, that they don't have a problem.
And why would they, if it's so obvious that they have this problem, why would they deny it?
And probably each individual has a different reason, but it's just that denial is very common. People don't want to give up their daily routine, their livelihood, their environment, and most of the time, if they're in denial and they're confronted by family and friends, part of the confrontation probably involves an intervention. If there's an intervention, many of you have probably seen on television that intervention show. I mean, it's very realistic. They're asked to leave their life for a period of time, go to a treatment facility where they have to follow somebody else's rules, and they have obligations and responsibilities, and there's discomfort associated with it, and they're unwilling.
Let's talk about the patterns of those individuals, those addicts who are in denial. Is it always the case that the family knows exactly what the family member, the addicted family member, is doing?
No, they hide it.
How do they hide it? What are ways that they would do that?
Well, they hide the use. They don't talk about the use. They keep the pills private or whatever they're using, and they do everything in their power to maintain their privacy and discretion.
In addition to hiding it from family members, do you see examples where they also hide it from doctors?
I have cared for a number of patients who will obtain prescription medications from a variety of pharmacies, a variety of doctors.
Is that referred to as doctor shopping?
Pardon me?
Doctor shopping? Is that how it's the slang for that particular activity?
Yes, one of them.
How would they keep it from family and friends, typically?
They just don't use in front of them.
Different schedules, for instance?
In a bathroom, in the bedroom, at work. Addicts who are in denial are very good at compartmentalizing. What that means is they keep different aspects of their life separate from the other aspects of their life. So what happens at work and what happens at home aren't intermingled.
I want to go back to let's say that you have a patient in front of you that wants help, okay? And you have you said the first thing that you do is to get them, first of all, stop using the drug, right?
Correct.
And we talked about cold turkey and how uncomfortable that was. What process do you go through to help them stop this drug?
Well, excuse me, understanding the symptoms of withdrawal, you direct medication therapy at each of those symptoms.
All right. Well, let's take, for example, opioid withdrawal. Let's say that a person comes to you, has a Demerol addiction, OxyContin addiction, Dilaudid addiction. What would you do to try to get them off that drug, or at least to help them get off the drug?
Well, there's probably two ways that are most commonly recommended currently. One would be opioid substitution therapy, and the two medications that one uses to do that are buprenorphine or methadone. I don't prescribe methadone, so patients do come to me for buprenorphine.
Could you spell that for us?
You're really testing my English background.
Well, some of us need to write it down.
buprenorphine.
Thank you.
Did I get that? Okay. Buprenorphine is a partial opioid receptor agonist, so that means it stimulates the opioid receptor but does not result in full expression of that receptor. And it's a really good medicine for immediately ameliorating the symptoms of withdrawal. but one must enter withdrawal first. So some patients come to me because they've read about buprenorphine and they're interested in getting a prescription for that to help them withdraw from their opioid.
What's the purpose of using an opioid, something that would stimulate an opioid receptor? What would be the purpose of that?
Well, the technique is, again, it's the broad heading would be opioid substitution therapy. And so what you're doing is you're substituting a legal prescribed opioid for an opioid that's being obtained illicitly. And you prescribe it in doses to initially make the patient comfortable, and then in a tapering schedule so that they come off comfortably. But the beauty of that is that that can be office-based, and it doesn't require hospital care or even facility care. It's very safe.
The purpose of that is to try to make the patient comfortable.
Yes, because the addict's biggest fear is that you're not going to respect the amount of discomfort that they're about to experience, and so they really need to trust that you're going to look after their problem. The second method of withdrawing is a more old-fashioned technique, and you just give lots of sedation, benzodiazepines, muscle relaxants, and other similar sedatives to treat all the symptoms of withdrawal without doing opioid substitution. And they're subject to patient and doctor choice, and they're both acceptable and safe techniques.
Tell us what types of withdrawal symptoms you would expect to find for someone that's withdrawing from Demerol.
Again, probably the symptoms from opioid withdrawal are not reliant on the specific opioid, but they consist of sweating, diaphoresis.
What's diaphoresis?
Sweating.
Okay.
Tachycardia.
Which is?
Increased heart rate.
Okay.
Muscular aches and pains, bone pain, nausea, abdominal cramps, diarrhea, severe anxiety, severe restlessness, insomnia.
How about chills?
Yeah, thank you. Temperature dysregulation, chills, hot and cold chills are very common.
If somebody were complaining about feeling hot on one side of their body and cold on the other, would that be consistent with withdrawal from an opioid?
It could be. And most people who have experienced it will describe it as the worst case of influenza that they ever had. It's very, very uncomfortable.
And so you try to ameliorate these pains, this discomfort, with a drug to allow them to get through those symptoms.
That would be multiple drugs.
Multiple drugs.
Yes.
Okay. Well, let's go to those. We've already talked about, I can't pronounce it,
buprenorphine.
All right, buprenorphine.
Probably it's better to use the trade name Subutex or Suboxone. Those are easier, huh?
Yeah. Well, I'm glad they nicknamed it. So.
We probably need a spelling.
Thank you for the easy one. Subutex, S-U-B-U-T-E-X, Suboxone, S-U-B-O-X-O-N-E.
Thank you.
And what other drugs do you provide?
Well, the commonly used ones are clonidine, which is a centrally active alpha receptor stimulant. It's commonly used as a blood pressure medication. It's a very, very, very mild opiate receptor agonist or stimulator. It takes the edge off the withdrawal a bit. It also treats the overactivity or hyperactivity of the autonomic nervous system, which is a common, which is the cause of all the commonly recognized symptoms that I mentioned. You use vigorous sedation with benzodiazepines. Valium is commonly used. Ativan or lorazepam is commonly used. Sometimes you use phenobarbital. That's a good sedative. You use muscle relaxants such as Robaxin, Soma, Scalaxin.